Thank you, James, and thank you, Alan. And my job, Alan told me that is actually to make sure that to introduce the speaker briefly, and also to keep the time. And so I don't know who's actually, it seems that nobody will be actually giving any signal in terms of the timing and all that. So I would actually appeal to the speaker that when I shake my pen down there, then it's probably around sort of 2 minutes left, okay? So wrap up your talk then, yeah? Because we have a whole range of speakers this afternoon, so hopefully we will be able to actually finish on time instead of getting overrun. Now today we will have, this afternoon we will have a share of the wealth of local experiences in Hong Kong. And in the past decade, and actually in the coming decade, we will be, there has been a lot of growth, and also there will be continue to be great growth in terms of the healthcare sector, both the public sector as well as in the private sector, and largely that's due to the aging population, and therefore there's been a lot of development here. So it's actually timely to have this Congress here in Hong Kong right at this moment in time, and where there is a lot of changes. So the first speaker this afternoon is Dr. Libby Lee, my good friend from the Hospital Authority. She's the chief manager who's responsible for the planning and development of hospital services in the Hospital Authority. And at the present moment, she's actually she's been spearheading some transformational changes, especially in the planning and design of the children's hospitals in Hong Kong. Her topic today is an old topic called function before form, but I'm sure she will provide us with some new insights. So, Dr. Lee, please.
Thank you, Dr. Fung. I'm watching you and your pen, so I will stop once you shake your pen. Okay, so Professor Delaney, Professor Barlows, thank you very much for inviting me here to share with you, as a clinician as well, our thoughts on physical design in our hospitals. But before that, may I take this opportunity to wish you every success in this Congress, and hopefully you have an enjoyable time here in Hong Kong. So today, firstly, I would like to give you a brief idea about our background, the Hospital Authority, as the only organization managing 42 public hospitals in Hong Kong. With such background, our concern in hospital facilities probably will vary a little bit from that of private sectors. Then I will focus on the evolution of our healthcare services within these years, which have implication on the functions we expect in our hospitals. And then it will impact on the design that we need. The last part is how we relate these functions to our facility design. So this is Hong Kong's policy on healthcare services. No one should be prevented through lack of means from obtaining adequate medical, or spelling typo, medical attention. With this policy direction, HA was set up in 1990s under jurisdiction. That is the Hospital Authority Ordinance. We are charged by the government to oversee all the public healthcare services via our hospitals and outpatient clinics. And the Department of Health is responsible for regulation for private hospitals, and they directly reported to our bureau, Food and Health Bureau. We run a dual system here, meaning that we have both public and private healthcare services, easily accessible by our citizens. So public healthcare service is highly subsidized, you can see that, by the government through taxation. We are spending approximately 2.4% GDP and providing 88% inpatient and 31% outpatient in the whole healthcare industry in Hong Kong. And let's take a look at our fees and charges. Probably it will give you some idea why we serve around 7 million patient bed days per year in our system. The subsidy rate ranges from 88 to 98%. Therefore, we do expect our service serve as a safety net for our citizens. We focus on underprivileged group, training, acute services, and services that require multidisciplinary care and innovative technology. In fact, these 4 functions are dictated by government that HA should provide to our citizen. So we run 27,000 beds in 42 public hospitals. 47 specialist clinics, and 73 general outpatient clinics. Here are some activities that we provided during the year, which aims to show you or show us that our premises are heavily used by our carer and patients. So easy access, clear wayfinding, and robust structure to wear and tear are essential elements for our facilities design. Here are how we organize ourselves. We have 7 clusters to administer our health services. And this is actually important because each cluster will have a set of hospitals. Their functions ranges from acute, tertiary, or quaternary care to infirmary care. So every hospital in hospital authority are not created the same. They serve different functions within the cluster. So when we are building a hospital, we look carefully about the role and function of that particular hospital within cluster. And you might notice from yesterday, from this map, this is Hong Kong map, different color of the dots represent that of the clusters. From yesterday's news that HS is going to refine the boundary of 7 clusters. So we're looking forward to refining the roles of each hospitals within the cluster as well. The 42 hospitals in HA are at different ages. Some are built in 1870s, and some are recently developed. And here is one of the examples, Kwong Wah Hospital, which was built in 1911, situated actually on Waterloo Road in Mongkok. And each hospital has their own uniqueness that we are trying to capture and also preserve. In this hospital, it was built in 1911, that's what I previously said, and it has a heritage at the heart of the hospital. That is a museum showing on the left of the slides. So it creates technical challenges to us in terms of redeveloping this hospital because we need to preserve this museum. The technical difficulties are on the building services as well as how we decant our service during redeveloping of this hospital. We have some new hospital as well, like the North Lantau Island Hospital was built in 2013, and it captured the essence of our latest service model, especially in the ward design. Now we go to our functions. Our medical system is evolving at our own pace. There are defined functions of hospital, like at the World Health Organization level. You look at the definition of hospital is some place provided inpatient facilities, diagnostic curative services, provide essential information for research, teaching, or closer links with other parts. But to us, these definitions are too general for local use. So let me bring you to a closer look at the changes that Hong Kong experiences in the recent decades. First of all, the demographic. We are facing a rapidly aging society. Our population grows from 6.7 million in 2001 up to 8.5 million in 2041. You look at the blue part of the bar, that is the proportion of citizens aged 85 or above. So the population size of our elderly group rises from 0.75 million in 2001 to 2.6 million. So basically by 2041, 1 in 3 of us will be more than 65 years old. And when you look at this bar chart, each bar is actually dictates the increase of elderly population of that particular year. When you look at 2031, you can see that the blue part dictating the proportion of citizens aged between 65 to 74, and the red and the green part is those more than 75. You can see actually we are not only aging fast, we are really aging up to, or we are all really living to quite an extreme age of the society. But what does it mean to us? We're not only looking at, in general population, how the aging population change. We also look at the population change by districts. So the mostly affected district in the coming 10 years will be in Sha Tin, Yunnan, and Tuen Mun. That will be probably on the north side of the whole Hong Kong. And the meaning to us is the hospital designs needs to be elderly friendly. Perhaps you also know that from a medical point of view, older people are more prone to fall. They have a poorer vision and easily confused by institutional design and rapidly dysfunction when immobilized. So when we translate it into our facilities, we hope that our facilities can provide measures to reduce fall, like the tiles we use, the bed that we provide, and also the interior design enhance the senses and also orientation. You can see our washroom have a big toilet sign so that our patient will not be confused and going to a male patient going to a female patient intentionally. No, not intentionally. And also the color of the wards. We tend to use bright colors so that they then distinguish where they come from. And moreover, we want to promote maintenance of functions like ward-based rehab areas. In the next era, if not this one, we do expect having more and more chronic diseases, which accompany often with an aging population. So let me take you an example of cancer. Cancer rate in Hong Kong is rising with an annual growth rate around 3%, depending on which type of cancer you are talking about. And in cancer treatment, there are multi-modalities, and our facilities need to facilitate one-stop service with all these modalities in close proximity. We can surgically remove the tumor, but we need more operating theaters. We provide chemotherapy, but we need aseptic pharmacy to produce the drugs. We provide radiotherapy, but we need linear accelerators. And also, nowadays, the most exciting part of the treatment is the discovery of ways to make use of our genetic information. That is, we can provide gene therapy and titrate the treatment according to the patient's genetic composition. That would mean that we need a big laboratory. And all these modalities of treatment are unheard of like years or 10 years ago. More importantly, we have strengthened our philosophy in healthcare system or healthcare delivery, especially in the era of chronic diseases. There is an inclination of moving from a highly subspecialized care to a holistic care. We're not only concerned about medical treatment of our patients, but also the psychosocial aspect. For example, we want to change the environment we provide to our cancer patients or dying patients. This is quite a common provision in International Cancer Center. This is not in Hong Kong, obviously. This is quite a common provision in International Cancer Center for patients receiving chemotherapy. This is a garden with an aim to calm and encourage our patients. Hopefully they can see hope, from their terminal disease. Another big group will be our kids. Just like Dr. Fung has said, we are now building our children's hospital. We do hope that the environment of the hospital has to be child-friendly so that they can combat the fear during their medical treatment. And in recent decade, we have shifted our service model. We have shifted from our focus from inpatient care to ambulatory care, which can reduce avoidable admission, enhance patient safety, and better patient satisfaction. And this service model will require physical setup that supports the logistic of a high-volume day service. Classical inpatient ward will not be ideal to facilitate such a change. For the aging population, we do expect more and more involvement of our community partners and carers. They will come to our premises to learn the skills to take care of their family and the community. They will come to our premises and help in taking care of the patient as well. So the hospital is no longer a building filled up with beds, but we hope that the hospital is really going towards the area of hospital without beds. Last but not the least, technology. Medical technologies is advancing. Here I show you the traditional setup of operating theater. It was arranged like a theater previously, and all scholars were standing around the theater to learn and share have intellectual exchange. But nowadays, the operating theater is no longer a theater, but a big room, having a lot of modern technology or equipments. And sophisticated audio-visual system is set up for intellectual exchange outside the operating theater, because of infectious control, of course. And there are also new technologies like PET scan, which require lead-line facilities. Hyperbaric oxygen therapy require floor area of 2-floor height. Robotic surgery hybrid theater needing a bigger operating theater floor area. With all this, how can we actually incorporate them into our local hospital capital projects? In our system, not all hospitals are created the same, and not all hospitals are cancer center. So they have different roles within the cluster. Take an example of this cluster, the Hong Kong West cluster, which is one of our teaching hospitals situated in these clusters. We got 7 hospitals over there. Queen Mary Hospital on the top will remain as our teaching hospital, providing acute, tertiary, and quaternary care, while Grantham Hospital will be an ambulatory care center, taking the advantage of the MTR going to happen at the south end of this island. So when we redevelop this hospital, we have to bear in mind of their roles. How we do it, we conduct a clinical service plan. Basically, we did it for hospitals and also clusters. Before any hospital capital work started, we will conduct a clinical service plan to map out the model of care, future service development, and the role of each hospital within the cluster. And this will inform the physical design of the hospital. We will look at the capacity planning by projecting the future service demand. That will mean the number of beds, operating theater, consultation rooms, bunkers that we will require like 20 and 30 years ahead. Take this example, although it's a bit small. We look at the New Territory East Cluster, which houses 3 main districts. That is the North, Tai Po, and Sha Tin. So we did the projection about the population growth and aging. And so we can predict how many, or project how many space, how many beds, how many operating theaters, etc., that we required when we develop the hospitals. So how we do the clinical service plan? We adopt a highly consultative approach with a focus on transparency and stakeholders' engagement. Doctors are human beings, but they tend to think that they know everything. So we conduct the process by 2 phases. Vertical consultation to all departments through surveys and interviews, and horizontal consultation by cross-disciplinary working groups. This is the survey that we used. We asked about the current gaps and their aspiration in future service development. And then interview section will follow. Usually we distribute these surveys to all the key clinical departments and non-clinical departments. And the return rate ranges from 90 to 95%. It's really high. And then we will interview the staff. Usually like 500 staff will be interviewed during this vertical consultation process. And after that, we have a horizontal consultation process. We will make the staff arrange themselves into groups according to different programs, like perioperative care, neuroscience. The group usually will have representatives from different disciplines, different specialties, and they have to discuss the service model they aspire to, and they need to come up with consensus on the model of care. Usually we will have around 15 to 20 groups studying different topics and involving around 300 staff. The highlight of this process will be their presentation of their aspired service model in the one-day seminar. That is in front of our chief executive, the hospital chief executive, as well as the management. And usually there's a lot of questions or challenges towards the speakers on their model of care. And once the model of care has refined and agreed, and then we can proceed to the next stage. That is, all this proposal will be captured in the written clinical service plan and are expected to implement it even before the capital works started, if possible. And they will be monitored whether their proposal has been implemented or not. And then we move on to the next phase. That is, the clinical services plan now is ready to be transformed from the function to form. Based on this plan, our capital team will continue their work, like functional briefing, space programming, architectural planning, and procurement, etc., etc. We always refer back to this clinical services plan during the site construction, and with the aim of bringing the aspiration of our service development into the design. So this is almost the process that we have taken for all the recent capital projects in the public healthcare system right now. Last but not the least, I cannot stress more The function of our hospital is changing, so the old style of hospital design may not be applicable for the modern medicine. And we do believe that a clinical service plan in place to map out the service development is a prerequisite for a good facility design. It is wonderful to have a beautiful and stunning hospital, but it is vital for us to have a functional hospital so that our medical professional staff can deliver their appropriate care to our patients. So I end my presentation here before Dr. Fung waving his pen. So thank you very much for your attention.
Thank you. Will you stay to answer one of two questions? Yeah. So any question from the floor? In relation to what Dr. Lee has provided? Yes. Is there any mic around or whatever? Yeah. You want question? Yeah. Okay.
Maybe a quick one. And then
Okay, maybe a quick one, and then yeah.
I wanted to ask a little bit more about how you broke everybody into the multidisciplinary groups and built consensus, and how you found that works, because it's a big culture change when you're making these shifts.
Okay. This is a challenging task. During the vertical consultation, that is through the interviews and the surveys, we know them quite well. Medical professional is not a big, community. We know them quite well. They usually will talk about the gaps involving other specialties. And so at that stage, we already can identify which specialties they should be involved in coming to consensus about the future service model. And also, we will look at the suggestions of the membership for this horizontal group. In case they miss out someone, we will suggest that they have to include those specialties or discipline behind. And at the end of the day, when they first meet, we will join their meeting and make sure everything is in progress. And so this is how we ensure that they engage the appropriate people. And most importantly, we work together with the hospital management, so the HCE or the CEO, so that they know the progress well, and then when things happen, they can immediately handle at the point of care.